I'm Dr. Frank Arena. I'm a interventional cardiovascularist out of Tulane University Lakeview campus, and I'm going to talk today about how to manage IVC thrombosis. These are my disclosures. I'd like to say thank you to the guys from New Cardiovascular Horizons, Dr. Walker, for having me here today. So how common is IVC thrombosis? Well, it's actually fairly rare, about 1.7 in 100,000 cases, and it'll occur approximately in 2% of DVT cases, most of which you're going to find are associated with IVC filter placement. It's about 35% associated with cancer, even if you don't know the cancer is there, especially in older people. And it's common among congenital IVC anomalies, which occur in less than 1% of the population. Other causes can be external compression, such as leiomyoma or abdominal tumors, and of course, renal cell cancers. So when would you want to consider an IVC thrombosis? Well, certainly phlegmasia cerulea dolens, abdominal pain if the occlusion is acute. People get phlebitis, post-thrombotic syndrome, which is venous skin changes and ulceration, as well as claudication. This is more for chronic IVC closures. Lumbar and back pain. Often people will get dilated veins that can cause spinal compression and irritation. The dilated veins come from the collaterals. Acute kidney injury, obviously from renal vein thrombosis, and caput medusa. I know a lot of people don't look at patients' bellies, but it's actually fairly useful. If you see a large varicose veins across the abdomen, it's a very useful physical sign and fairly specific for IVC occlusion. So what are the symptoms? Again, post-thrombotic syndrome, about 90%. Again, these are more of the chronic people. Venous claudication in about half. Pulmonary embolism, that's more of an acute setting, obviously. And venous ulceration in a fair amount of people, which is a very significant symptom. And what does the data say? You would think that just opening the main vein coming from the lower extremity would be a good idea. But surprisingly, there's a real paucity of data about this subject. There's a few meta-analysis saying that's a good idea, but really we only have one good randomized controlled trial in this area, and it's called the ATTRACT trial, and it had a fair amount of controversy associated with it. And this trial stratified proximal DVT into iliofemoral DVT and fem-pop DVT, and then randomized each to catheter-based thrombus removal versus anticoagulation alone, following up for 24 months with Velada score, SEEP, quality of life, etc. And as you can see, the original study made some headlines, was again controversial because it did not show a difference in any post-thrombotic syndrome between treatment and non-treatment. But Dr. Camarata did a sub-study and was able to show fairly well that it did improve severe post-thrombotic syndrome scores, which is really the people that we need to try and help the most. As you can see to the right side of the screen, Velada scores of more than 10 and 15 were all statistically significantly improved with treatment. And this is just another slide showing that the curves separate fairly early and stay separated long term. So when to consider and how to diagnose IVC thrombosis? Well, this was a nice slide from Jack Intervention back in 2016, and I thought I would use that. So if you have DVT and some high-risk features for IVC thrombosis, which include an unretrieved filter. Now, some filters are worse than other filters. Certainly, some of the older filters are a larger problem. Proximal iliofemoral DVT, bilateral DVT, unexplained new back pain or renal failure, known IVC congenital anomaly, severe post-thrombotic syndrome, or renal cell cancer or Budd-Chiari syndrome. Often an IVC duplex is quick and easy way to make a diagnosis, and you have to stratify if you can get a good picture with the ultrasound. And now if you can, then you can you can check to see if you have IVC thrombosis, if you have a good picture. And if it's ruled out, you're going to treat people with regular anticoagulation. If it's ruled in, then you have to make a decision whether or not it's a good idea to treat the patient. Other scans you can use, if the ultrasound is not a good image, is CT venography or MRI venography is sometimes helpful. And obviously a venogram from either a femoral or popliteal, or in my case, a lot of times I'll use an infrapopliteal access with ultrasound guidance can be very useful. Now, so if you're going to get into this, you certainly want to understand the anatomical variations. And on the upper left, you'll see is the normal anatomy of the veins to the arteries in the abdomen. And the three to the right of that normal is pretty much what you need to be aware of. And there are various levels of right and left duplication all the way up to a full left-sided IVC. And so if you decide to fix it, there's a certain decision tree that you have to go through. Once you've confirmed the IVC thrombosis, you have to ask yourself, is the patient high risk for bleeding? If the patient is high risk for bleeding, do they have very high risk symptoms like renal vein thrombosis or phlegmasia cerulidolens? If no, perhaps regular anticoagulation. Often in older people, that's all you're going to do. And if yes, sometimes you have to go in with a direct thrombectomy, maybe an angiovac or Clottriever or Penumbra Cat8. And I would say a low dose power pulse because everything is relative in this world, and there's very few people that 10 milligrams of TPA in a power pulse setting can't tolerate. Now, that's not to say that if somebody has a bleed in their brain, you're certainly not going to do that. But regular old anemia generally is well tolerated with 10 milligrams of TPA. Now, if they're not at high risk for bleeding, certainly you can consider an endovascular approach, and you want to consider the chronicity at that point. Now, if you have something acute that's less than 14 days, these things are going to clean up fairly readily with catheter-directed infusions, ECOS, POSIS, power POSIS, or any basic check technique using TPA, they'll clean up well. Subacute, they're going to be a little bit more firm. Often you have acute on chronic DVT that you're going to have to deal with. And in subacute, often you'll have some firmer substances that you need to go after with a Clottriever or a Penumbra to clean up and open up a little bit more. And obviously you have to deal with the filter sometimes. And often it's kind of surprising, but often the filter can form webs. And it's very interesting. You'll see flow changes going through the filter. It just looks a little bit sluggish. And you go in and you actually balloon between the struts. And then the flow improves substantially, even in things you really can't see all that well. So you have to consider flow whenever you're doing any of these procedures. Now, chronic, obviously, is more than 28 days. These things are going to be very firm, hard, scar. They're not going to respond very well to TPA at all. So you're really going to need more just sharp dissection techniques. You're just reopening total occlusions and stenting those as large as you can. And you're going to want to use IVC guiding to make sure that your stents are as large as possible. And you may want to consider keeping these people on lifelong anticoagulation, as the anticoagulation protocols for these people is really unclear in the literature, and it's really just done by what you feel is necessary. But I often keep people on at least some level of anticoagulation going forward. And often, if you'll have to repeat these cases as scar forms and as things reocclude. These patients have formed a large amount of collaterals, and often, if your flow isn't better than the collateral, your flow will close. So here's some cases. People love cases. This was a nice 57-year-old lady with HIT and 2 pulmonary embolisms and a trapeze filter. Now, trapeze filter is one of those filters I was alluding to earlier as being problematic. They occlude often. I remember Dr. Camerata telling me that little pearl back in the day when I used to put a lot of trapeze filters, and it made me very nervous. And this lady occluded on Coumadin and was suffering greatly with chronic edema, severe post-thrombotic syndrome, non-healing wounds on her left leg. As you can see, we went through and we opened it with sharp dissection techniques all the way up to the filter itself. And then most of the filter looked fairly good, at least the more proximal end of the filter. And we were able to open it up with 14 millimeter wall stents in a double barrel technique, which is common all the way up through the middle stage of the filter in order to preserve the proximal stage to help prevent any other PEs that may occur in her. So this gentleman, 42-year-old gentleman, now he had originally occluded at age 17, and he presented to us with very severe symptoms. He had severe post-thrombotic syndrome, non-healing wounds, was in terrible levels of compression, couldn't work, disabled. He wasn't obese or anything of that nature. He just really was suffering from this. We felt that he probably had a Budd-Chiari syndrome, which contributed to this occlusion. So as you can see, if you were watching the pictures, he had various levels of chronic DVT going from his infrapopliteal veins all the way up through his iliofemoral veins and up through his IVC. And it was quite interesting. We started as usual from the posterior tibial veins on both sides, worked our way up, ballooning through the scar, get up into the main portion of the IVC, and it was closed. We were quite frankly, we were expecting to be open. Usually these things are open at some level. But we had to just keep going, keep going, keep going, keep going. All of a sudden, we're at the level of the heart. And quite frankly, I was like, well, what do I do now? So I called Dr. Walker, actually. And basically, over several cases, we decided to repair this with some very large stents from the base of the right atrium all the way through down to both femoral veins. And I just saw this gentleman yesterday, about 2 years on, and he's not the most compliant guy, unfortunately, but he is doing very well. And all of his wounds are healed. He has no significant edema. He still has his caput medusa, which I think is collateralizing off a lot of his organs. But he's quite happy with the ongoing result. Thank you very much. Appreciate your taking the time to listen to my presentation.